Thank you. Thank you for inviting me here. And thank you, Zenon. It was just great to hear that talk. And so I'm going to continue in the area of mental health um, and talk about our PHIND-funded study in which we're predicting the onset of depression and suicidal behaviors in adolescents. So Zenon talked a little bit about depression. Let me just say a few more words. It is the leading cause of disability worldwide. There are more than 300 million people diagnosed with major depressive disorder. And it's really more than any other physical or emotional disorder or disease, including coronary disease, diabetes, et cetera, with an annual cost of about $500 billion. It's a recurrent disorder. So once you've had one episode, you're likely to have 5 or 6 over the course of your lifetime. It's also, importantly, a significant risk factor for suicide. So we have an increased mortality rate of people with a diagnosis of depression. That's almost 3 times the national mortality rate. Excuse me. And about 2/3 of suicide victims die in their first attempt. So suicide is unfortunately prevalent, almost 1 million suicides annually, and 40,000 of which deaths in the United States alone. Twice as many suicides as homicides, 5 times as many suicides as HIV. And I just want to show you that from 1965 to 95, taking the peak numbers, to about a decade ago, we've seen decreases in stroke and AIDS and heart disease. In fact, virtually every disorder except suicide, which has remained flat and is still obviously a problem. It's particularly a problem in adolescents, both suicide and depression. Both of these, depression and suicidal ideation or suicidal thoughts, are precursors to a suicide attempt. And you can see here that first episodes of depression here go up starting around puberty, age 13, 14, 15, and continuing through adolescence, where now about 25%, 1 in 4 adolescents will develop an episode of depression. 60% of these adolescent suicide victims actually had a depressive disorder prior to their suicide attempt. And suicide, not surprisingly, is the second leading cause of death in adolescents after accidents. The problem is that these statistics have gotten worse, leading to media articles like, for the last 80 years, young Americans have been more anxious and depressed. The American Pediatric Association, all teens should be screened for depression. Suicide rates are climbing in the US. So obviously it's important to be able to predict which adolescents are going to develop an episode of depression or to engage in suicidal ideation. But we haven't been able to do that, in part because of limitations of previous research. So previous studies have been these cross-sectional assessments, in part teenage versions of what Zenon was describing, these studies of depressed or suicidal adolescents, but that doesn't help us with risk factors, often just based on subjective reports with small samples and typically a single risk factor in any one study, making it really difficult to understand how risk factors might interact. So with PHIND, what we're doing is trying to identify and integrate longitudinally neurobiological digital phenotypes of risk to try to get precise monitoring of changes in biomarkers in the biology, affect, behavior that might predict the onset of depression, suicidal behavior in adolescents. If we can predict that first, if we can prevent that first episode of depression, we can prevent a lifelong negative cascade of depressive episodes. So we had recruited and we had been studying a cohort of 200 healthy boys and girls who had been exposed to a range of early life stressors. So prior to funding from PHIND, we conducted 2 comprehensive assessments of these children. And you can see that we assessed them when at time 1 and time 2, 2 years apart, when they were 9 to 12, and then again 11 to 14 in this window. But with PHIND funding, we now extended those assessments to 2 more years, to time 3, time 4, age 13 to 16, and then 14 to 18. And so based on the epidemiologic data that I showed you before, we had expected that about 25% or 50 of the 200 adolescents would experience depression or suicidal ideation. It's exactly what we're finding. What we're doing with PHIND funding is measuring inflammation, so pro and anti-inflammatory cytokines. We're measuring diurnal cortisol. We'd already been doing neuroimaging. We continued to do structural, functional, diffusion imaging and connectivity. We also added a sleep and mobility assessment using an ActiWatch. And finally, we're using experience sampling to do 3 times a day, having them respond on their iPhone, adolescents respond on their iPhone using an app by MetricWire about their affect, their social behavior. Okay. So I'm going to present, where are we? 11:30. We have till 11:40, I think. So I'm just going to present some findings and then talk a little bit about COVID and what that did to our study and what we've done. So what we're finding is that we can now predict the onset of depression and the onset of engaging in suicidal ideation from data that we had collected through PHIND. So here with IL-6 and TNF-alpha with inflammatory cytokines, we can see that these cytokines are higher in children who are subsequently diagnosed with depression than they are in controls. We also see that levels of IL-6 and TNF-alpha are predicting increases in suicidal ideation as well. So we have an inflammation marker of the development of depression and subsequent engagement in suicidal ideation that we think is promising. We're also seeing patterns of brain activation that are predicting greater severity of both depression and suicidal ideation. So reduced brain activation in the ventrolateral prefrontal cortex is predicting higher depressive severity and greater suicidal ideation. This reduced brain activation, in fact, is mediating the association between severity of early life stress and symptoms of depression and anxiety. So early life stress seems to be working through patterns of brain activation to predict the development of depression and suicidal ideation. We're also seeing structural findings here where we have lower gray matter volume in reward areas, caudate, nucleus accumbens, and putamen, that are predicting greater suicidal ideation as well. So, and finally, sleep satisfaction. So measured with the experience sampling and with the ActiWatches that we're having them wear, is also predicting increases in lower sleep satisfaction on the left, predicting greater severity, greater suicidal ideation. So the measures that we've been including with our PHIND funding are actually helping us to predict which adolescents are at greater risk for developing depression, for engaging in suicidal ideation. And then COVID came. right? And Stanford, as you all know, shut down. And we have article after article about teens and mental health during COVID. So we shut down in-person research. At the time that the shutdown hit, we were about 2/3 of the way through the T3 assessment. We were just starting T4. That was March, a year ago. We took advantage of the lemonade, tried to make some lemons, tried to make lemonade with the lemons we were given. We administered an online survey to our participants about a month after shelter in place. So April, May, they completed some self-report measures, coronavirus health impact survey, in addition to measures of depression, measures of mental health and stress. Let me just show you, I'm tracking time, I can wrap up pretty quickly. Let me just show you some COVID-related findings from this PHIND study. So with Raj Chahal, who's a postdoc in my lab, what we're finding here, not surprisingly, is a marked increase in internalizing fear, depression, sadness from before COVID to during COVID. And we're also finding that greater early life stress is predicting higher levels of depressive symptoms through the COVID shutdown, and that seems to be mediated by their levels of perceived stress. We're finding brain predictors of negative affect, depression, sadness, anxiety during COVID. Again, these prefrontal areas. And Raj Chahal, again, the postdoc in my lab, thought it would be important to look at resilience. So some adolescents are actually doing okay during COVID, much better than you would expect them to be doing. So we have a group who seems to be resilient. Raj thought that executive functioning, that is cognitive control, emotion regulation, neural network, would really help with understanding who's resilient, who's not. And in fact, what she found is that greater coherence of this executive control network is protecting adolescents against the increase in internalizing or depression that they would see otherwise with advancing pubertal stage during COVID. So we're excited about our findings. We're back up and running. We're now integrating these time 1, time 2 data and starting to get promising findings to identify kids at the highest risk for developing depression and suicidal behaviors. We're going to be able to do machine learning, other AI analyses once we're done with the T3 and T4 assessments in order to develop more tailored approaches that can be scaled to identify these kids at greatest risk for depression, suicidal ideation. Other members of our team, Trevor, Holden, Rachel Dennis, and Tiffany, Jackie, Erica Jonas, my lab, and just let me thank you again for allowing me to share these data with you.
Thanks so much, Ian. Yeah, that it's really just super important work, especially during the current time. And it's just been really exciting seeing all the data that you've been able to obtain. You mentioned, you use very interesting data sets. You have immune data, you have structural, functional MR data. Were there any just truly surprising biomarkers that jumped out at you that you didn't expect, through this journey of please.
Yeah, no, it's a great question. And it's because, so immune functioning, there are data I didn't present about biological aging. So we're measuring telomeres, we're measuring methylation. It's all, I think, a story about stress sensitivity. And I think what's happening is that early stress is making these children more sensitive to stress. And that's being reflected in their immune function, their shorter telomere length, their greater methylation. They look like they're older biologically than they are chronologically. And that's part of the inflammation story. So we were surprised that we'd find it in kids that are as young as 13, 14, 15, but we are. And I guess, we shouldn't have been surprised, given that's when we're seeing depression, that's when we're seeing suicidal ideation comes. But we are now finding the biomarkers that we had hoped for. It would be interesting to work with Zenon to see that we can do some less intrusive things. We're still doing finger pricks for blood and saliva for cord and for telomere length and methylation, but doing, a cortisol wearable, for example, or heart rate. So there are things that we could still do, probably by recruiting a new sample. These kids didn't stop aging through the pandemic, unfortunately, even though our research stopped. So we're starting to get them back, but we're going to have a real I want to say post, but I'll say pre and then during COVID difference that we're going to have to deal with somehow.
Right, absolutely. I also wonder, that you have so many interesting measurements. Some are going to be fixed, some are going to change over to be more dynamic, I think. And so, I think with any type of this kind of continuous type monitoring, it's always interesting at the frequency of measures and the depth that's necessary. I wonder, as you think about, scaling this, to at a more population level, do you have thoughts on, the types of measures you think that might be, because building the model, obviously you can add or subtract things and that can make it better or worse depending on how good the data is.
Yeah, it's a great question. We've really thought long and hard about this. We can't do brain imaging, right? I mean, there are things that are scalable, more and less scalable, but we can use the brain imaging to refine the ESM, the experience sampling, iPhone data, to refine the inflammation data. Again, these are finger pricks. So we can actually do these at a scalable level. So we're hoping to get algorithms in kind of an analogous way to what they're doing with polygenic risk scores, right? Now it's not a genome-wide association study, it's 7 specific genes. So we can try to do that with a combination of saliva and immune function in a much larger sample. ABCD is the adolescent behavior cognitive development with 14,000 kids. So there's a way to do that. That's not intrusive, but we need to, what we did, I think, was important in helping us to identify what we want to measure in these kids to reduce it to a manageable assessment. And I think we can now do that with the data that we have coming in.